Okay, well, I don't have many slides. I actually took out about 30 slides. I've just been left with 5. So, I've already spoken about how I believe our health message, or the lack of a very clear health message, is in fact allowing stigma to reside within the population. It's just lodged there and we're just not getting rid of it. Stigma is not motivated by persons being evil or disliking other people for horrible reasons. We have to look at human behavior as making rational choices. And what I already explained in the welcome remarks yesterday, but for those who weren't here, the fear, the outright fear of HIV, that it's a death sentence, this may not be true in all countries where we've managed to get the message across, but in the Caribbean, we are incredibly traumatized when HIV hit the Caribbean, and the public thinks this is a death sentence. So when you have that understanding of a death sentence, then it becomes rational not to really want to know your status. Why would you want to know your status if you're just going to be handed a death sentence? And correspondingly, that fear in our hearts and our minds is driving the stigmatizing attitudes towards person who has HIV because we're afraid of them. So I wanted to rethink the way in which we reach decisions, and I did a little bit of research about the theory of self-interest, and most of the research is actually done in the world of economics, but it's a very powerful theory which governs behavior. There are not many. We're all in public health, right? Clément, you're now the public health lecturer. Isn't it the hardest thing to actually ask people to change behaviors? I mean, it's a very difficult thing. But what has already been demonstrated very abundantly is that the theory of self-interest is a very strong mover of behavior change. So I'll just read a little excerpt which comes from the world of economics. Individuals, groups, or companies, or legislators will seek to enhance their self-interest. They are assumed to be rational in assessing the benefits and the costs to themselves of their actions. This theory enables us to make assumptions and predictions about individuals and group behaviors. So that is really the theory of self-interest. Now let's think about how that applies to public health and HIV. One thing that we have to be very clear about in our health messaging is the difference between AIDS and HIV. We tend to kind of, use them in our acronyms, CHART, there's so many things which is like H and A together, because A is a very useful, vowel. So we have them in all of our acronyms, but it's very different, This, of course, is Joseph Jern, who was the star of the Montreal AIDS Conference. And of course, I'm not being mawkish here because his is a great story of resilience and life. But here he is living in the shadow of death. He has AIDS. In this world, nobody should have AIDS. Nobody. Because we got the treatments. You can have HIV, that's fine. I mean, HIV is no longer, quite the sort of tigerish virus that it used to be. It's sort of now, it's a pussycat that sort of meows quietly because we can suppress it. So, it's okay to have HIV. We carry a lot of viruses in our body. It's not okay to have AIDS. We should never have AIDS, and we shouldn't conflate the two. Okay, so we know how to eliminate AIDS. It's the easiest thing in the world, right? Or is it? This is Joseph Joan, and he is living in the shadow of death. I can see it behind him. And if you look at him now, he, at that point, was a father of 2 children who were HIV negative. Joseph did die, I think 2 years ago. Eventually, he succumbed to comorbidities. It was actually TB that he died from. And he loved the fact that this picture was used. It's the embodiment of what antiretroviral treatment is. It's basically the difference between death, which is AIDS, and living with HIV. Living with HIV. So it is that simple, and it isn't. Because it's very difficult to get the person suffering from AIDS to be treated. And this is why. We have the barriers. We have the barriers. We have the barriers in diagnosis. And even after you are diagnosed, the barriers to linkage of care. And of course, that is due, as I've already mentioned, due to fear. You don't want to know your status because you think it's a death sentence. If we can at least overcome that fear, we should get more people wishing to be tested. And of course, the linkage to care, it's a huge stigma when you are receiving care, and everyone has spoken about this. We have our own peculiar stigmas in the Caribbean, particularly in the very small islands, because people know where the HIV clinic is. We have some patients who actually dress up in scrubs when they go and get their antiretroviral treatment because they want to sort of fool people into thinking that they're an ancillary healthcare worker and not getting their drugs. And even when someone is linked to care, for this treatment to work, you must have good adherence and you need support. But what do we actually have? We have discrimination and isolation. So that simple paradigm, which really is all we need to do to eliminate AIDS, and then of course through treatment or prevention, through the passage of years, eventually we will eliminate HIV. It just requires us to overcome these stubborn barriers. We must overcome these. So I want to just expand on the opportunities that come about speaking about treatment as prevention. Treatment as prevention, we recognized from quite a long time ago, was a very good thing, and we could see that it was having effects. I think it was the 2012 or the 2013 UNAIDS report. There was a very triumphalist report which had all these bubbles, and it showed 70% suppression of new infections in Malawi and 80% in some Caribbean countries and 50% here, 60% there. And these were over 10 years. So 10 years of treatment led to these big drops in new infections. So at some level, it is definitely working. Okay, so when it comes to stigma and discrimination, I actually forgot what stigma and discrimination meant. I had to go and check it in the dictionary because, in our field, we sort of, it's like a cliche, stigma and discrimination. Have you had your S&D training? Yeah, I went to the TOT, the train of trainers S&D training. I couldn't even remember what it meant. So I looked it up. So stigma is a visible sign or characteristic of disease, or a mark of disgrace or infamy. So it is something visible. The buffalo hump is an obvious sign of stigma, the lipodystrophy. Discrimination is an action. So discrimination is the unjust or prejudicial treatment of different categories of people. But when I continued looking in the dictionary at the dictionary definition of discrimination, I found some other definitions. I don't know if you can see this. I'll just read it. One of them is discrimination is the ability to see or make fine distinctions. and it is discernment. Okay? So what is the difference between the prejudicial discrimination and this rather wonderful form of discrimination? And I would posit that it is fear. Fear, when you are afraid, you are only going to be acting out prejudicial treatments of categories and groups that you're afraid of. But in order to be able to develop the finer forms of discrimination, you must have information. And this is where I think we've been going wrong with our public health messaging. We've been keeping information to ourselves. We know that we can bring down new infections, and maybe, despite what the mathematical modelers say, if we put sufficient people on treatment and we reach sufficient people, then we will bring down new infections and we will treat our way out of this. But the problem we have is that here in Barbados, and we've had this, we've seen this kind of thing before, our problem is not really in getting people to know their status, or even, which is here, our big drop, and we were the second country after the US to have a national cascade, is actually the linkage to care. People know that they have HIV and they're just terrified to come and receive treatment. And the majority of persons who enter into our treatment program actually do so through the emergency room of the hospital dying from AIDS. So this is discrimination in action. After that, we do great. And Sten's HPTN 071 study, I know he said that not everyone has had a master's in public health here, but that still looks like a pretty crack team to me. No chips in that. So that is the crack team.
That's the research team.
Okay. So, the point I would like to make, and you kind of alluded to this in 052 and in 071, In 052 you said that, we practically adopted people and took them home. And in 071, you've gone a very long way to have these outreach, but really there is no substitute for the support of your own family and your community. And that is ultimately what is going to allow us to reach everyone. So I just want to fully agree with, and this is not a new position or anything, with these two excellent statements, one from the research side from Anthony Fauci, and one from Deborah Birx, who I've never met but also makes a lot of sense. This is all exactly what we've all been talking about. So the virus is not going to outflank us. We have the science to beat it. The problem, of course, is whether clients feel they can access treatment, whether they want to know their status, or whether there is too much stigma and discrimination at the community level, that they feel like they can't access it and know their status. That's what I've been saying, so I'm not the first one. And I would like to propose that we change our public health message. We speak about treatment as prevention. I do it in what I call the taxi driver test. I try it in different countries. I try it in different parts of the world. Taxi drivers are very gregarious, chatty, communicative people. They get it in seconds. You simply say this, look, if you are feeling with the words that you speak, you're having discriminatory thoughts about people who have HIV, those people actually will not wish to know their status, they won't get treatment, they're going to be walking around with very high levels of virus in their blood. But however, if you take an enlightened approach, and you know maybe through friends or your community that someone has HIV, say look, it's not a death sentence, please, go and get treated, we have the drugs available here, and that person will become treated, his virus will be suppressed, and you've made yourself safer. So it's rational self-interest. And I think we need to capture some of the optimism about that this is not a death sentence, that's an absolute must and a given. And Cesar Nunez said, we really should talk about the successes, We've now got over half of people on treatment. We're turning the corner. We're in this fight. And so in the next slide, I just want to, Andre, you're going to have to participate here. I want to explore a few health messages. You've already heard my little pitch, test, treat, defeat. You can kind of get people going, test, treat, defeat, maybe with a Caribbean sound, a beat. Eddie says he likes it, but, it's not going to be the final message, I'm sure. You can write down, are we permitted, or is there a kind of a copyright on the Dutch message, which is U equals U. Undetectable equals uninfectious. Can you write that one down? Capital U equals U. Undetectable equals uninfectious. Okay, so I'm sure you've all been thinking about your own little messages. Can we have a few starters? Anyone want to volunteer? How about from Haiti? Any public health messages that you use are very open, which discuss the fact that when someone's on treatment, they're non-infectious? Does anyone have these kind of messages? I did see one in Sten's slides where it was something about PMTCT. We seem to be much happier talking about treating mothers not transmitting to their babies, but whether it's horizontal transmission or vertical transmission, it's the same principle. So Tom's scratching his head. You've wait, it's like an auction. Were you bidding or just scratching your head? Okay, so maybe let's just hear whether this idea is barkingly insane or not. So, does the theory of rational self-interest hold any water? If the CHIPS health workers spoke openly about eliminating or preventing transmission of HIV in the community, do you think that would engage persons more than just speaking, about it's the right thing to do to treat people, etc.? You're nodding, Barrett? Yeah? Yeah. We need to be positive. We must be positive because, we think we're going to win this. Brendan?
There's something that I picked up in the things that you've been saying. I wanted to ask, by the way, who is the we when you say we must do this and we must do that? But don't respond to that yet. Adherence and support are two key factors that you have identified. So should we be encouraging our patients, instead of coming to see us individually, to bring someone as a supporter
I like that.
into the interaction? Recently, one of my patients did that without asking my prior permission. And so there's a threesome that's interacting
Excellent.
now. He says that this other man is his mentor, his support system. And I've agreed to that. Should we be doing that more often? Should we change the model of the private visit?
Yeah. And that actually feeds in, of course, to what Raymond Noel, who runs a very innovative public health, a family health clinic in Tobago, and he creates what he calls, a cocoon of support around his patients. So he encourages them to come in with their family, to share the experience, to talk about it. And then, of course, he treats the mum for hypertension and the dad for diabetes. And, and as part of the whole family health clinic, he creates these support networks. And he has presented at our meetings that the percentage of persons who remain in his clinic on first-line treatment is very good. So I would say yes. I think that's a great idea. George, use the microphone, please.
Maybe I'm just going back one chapter in your talk. It just occurred to me that would it be rational to actually make some critical comments? Basically, there is a homosexual population who I can imagine incredibly caring and very, very homogeneously supporting, and here to get through a message is already have been done. But I am wondering what is the situation of the incredibly poor, impoverished people who are so badly living that they kind of lost the will to live. And we heard yesterday that poor woman who becomes prostitute because of the stigma. So isn't there a kind of scenario when those people who are queuing up for food and that kind of thing, then kind of somehow give them money support and advice where to find the HIV clinics?
Yep, if I can respond, I completely agree. So when you have a family support unit, and we start breaking down some of the fundamental fears. So the death sentence is essential that we challenge that, and you can start bringing in family members as support. That's something that works. You spoke about supportive networks among gay communities, for example. We have very open testing efforts in the Caribbean and in Barbados, and by and large, we do not capture a lot of new cases through those. A lot of people come, they already know their status, that they're negative, they might be in a new relationship, and both persons come again, and there is certainly nothing wrong with that. But what we have found is that in work in the communities where you have a key individual who is respected in their community, and we can use the example of the gay community, very quietly, completely under the radar, without any, spotlight from the public health sector, encourages members of their community to become tested. In those ways, we have found a lot more people here in Barbados, and that is very effective. So, and then you spoke about people who really are pushed right to the margins of society, who really have lost maybe the will to live, they've lost their supportive networks. Maybe they are what Sten called, the last 10% who will require 4 times the resources as the first 80% to reach. And in that case, you could see how a trained psychologist who, in Diana's program, they met with 5 times, was an absolute lifesaver, as the person put it, a quote. So I think it has to be all of the above, and I think they can all work. Yes, please. Use the microphone.
My name is Taylene Carver, and from Baltimore, and I just wanted to kind of just have like a little bit of reflection. In that slide where you show stigma and like sort of fear reproduces discrimination, just to kind of keep in mind that there's other domains that could be associated with the production and reproduction of stigma and so on, discrimination. And just like with the work that we do with sex workers, one that comes to mind is culpability, just feeling like this is a punishment for being involved in sex work. And just trying to keep in mind that there are different domains that may kind of all work together to produce this in the messaging and how we direct our communication strategies to like different populations.
Do you have a a feeling for what could be a good communication strategy? Any instinct?
So I don't think that so this is kind of something that we're working on right now. So off the top of my head, I just feel like it's not a homogeneous
It's not.
message. And we do want to keep that in mind. And I know this was mentioned before, we're not a homogeneous population. And I think keeping that in mind as you move forward with the messaging strategies. So with sex workers, for instance, another domain is this idea of judgment.
Right.
So just like really reflecting on what are the domains that are really driving and reproducing stigma, and then trying to address those while keeping in mind structural stigma as well. Things that are not, internalized, but they're produced by policies, they're produced by
like you had said, the
yeah.
closed doors, when someone
Exactly.
wants to achieve care, the door is shut, and then someone needs to come and help open it. Yeah. It's actually very unusual to be in front of a Barbadian audience and not get lots of questions from the Barbadians, because I love hearing Barbadian questions are usually the most insightful and hardest to answer. So if no one asks me a question, I'll be quite happy, because Barbadians always ask difficult questions. Yes, please, Patrice?
I'll just give an example from our situation in Haiti. As you know, it's a very poor country. More than 60% live under $1 a day, and they don't have food usually. So they will come to the clinic and tell you, doctor, we don't have food to take the pills. So one positive message we develop is, even though you don't have food, you can take the pills, and the pills will help you live longer in order to find a way to find a job, and this has helped a lot.
And that's a good, nice, positive message. I like it. Are you? Did you have an idea? You were scratching your head. Any other inputs? All right. Well, I'm finishing early. Let me see if there's anything else. We've had that. Oops, I'm going the wrong way. Oh no, I'm not. Gosh, this thing really is topsy-turvy. Huh? Oh yes, a little just background on our meeting. It started off with the Ministry of Health, and the Ministry of Health and Akin was the leading light in the first two meetings. And then in 2006, CCAS was born. Is Akin here? There he is. And Akin, he's a very shrewd operator. He went on sabbatical to South Africa, and he needed someone to keep this meeting going. So he created CCAS. And as he says it, it's not that I gave Clive a job he couldn't refuse. I gave him a job he couldn't understand. So anyway, so that's what I took over. So we started off with CCAS, and then we started building very consciously these extra linkages with the leading clinical training arm, which is the Caribbean HIV/AIDS Regional Training Network, and the CDC. The CDC urged us to approach CHART. So we had a sort of nice triumvirate going. That came to a sticky end, which I can only talk about when I have a few drinks in my hand. And our very long-standing collaboration has been with CMLF, and that's the Caribbean MedLabs Foundation. And tomorrow, Valerie Wilson will be talking about 10 years of data which we've collected. Cesar, you wanted new data from the Caribbean. This is new data. This is from our own meetings over the course of 10 years. Every single year in the country reports, we get standardized questions, particularly about the capacity building. So it's going to be a retrospective of 10 years of capacity building. It's going to be brand new. You will like it. And then, as you can see, we've now shrunk back again to just being CCAS. And that is, again, due to very unfortunate funding drying up from regional donor countries. So that's a little bit of history about CCAS. And our aim, it's a registered charity, and we have a honorary auditor who provides reports to the Charities Commissioner, and it is to improve access to antiretroviral treatment in the Caribbean by removing technical and social barriers to care. So technical barriers would be, we didn't have any CD4 instruments, when we first started, and now there's nearly 200 in the Caribbean. And then our CCAS is based on volunteerism. It's actually not just us who are volunteers. All of our faculty, none of them get paid. So we're real cheapskates. But it's a mixture of persons from the Ministry of Health, from the private sector, and from UE staff and students. So the staff, it would be me, and the students are my PhD students, and there's no coercion there. And so that's currently who are the members on our committee, but other serving members appeared yesterday, like Sonji Branch and Kelly Carmichael and Shauna Marshall, and Vera Lane, of course. She's sort of moved up to being president. But so it is a charity, and it has been growing, and I think we intend to continue these meetings. So as long as you're all okay with the concept of the Expert Summit, and UNAID's still happy with us, we'll keep it going. Okay, all the persons we trained from 23 Caribbean countries, and I think I will end my presentation there. Thank you very much.